I would like to thank everyone. This is Manos Brilakis here from Dallas VA and UT Southwestern. It is a great pleasure to introduce to you Dr. Tony Spaedy from Missouri Heart Center in Columbia, Missouri. Dr. Spaedy is one of the world experts on CTO intervention, and it's a great honor and privilege to have him present today to us some cases. He has 3 very interesting, challenging cases that he's going to present to us. Also need to acknowledge that this webcast has been supported by Grants from Terumo and Abbott Vascular. We appreciate very much their support. And without further ado, I will let Dr. Spaedy take the lead. So, Tony, again, thank you very much and welcome on the webcast.
Hey, thank you very much, Manos. We have 3 cases, just as you mentioned, kind of mostly cases that I think we learned a lot from. And then we were talking a little bit ahead that we're going to show a couple slides at the beginning just on radiation, just because we're using the zero gravity now, and I wanted to show a picture of it and just show you some things that our radiation safety officer had shared with us here recently. And the first slide you see here is kind of interesting. This is just the change we made from 2011 when Aaron Grantham, or this is actually before Aaron came to do our first proctor visit in 2011. They measured our doses from the different people in the cath labs, and generally everyone wears very consistently their badges, and they're measured by our safety officer and logged. But you can see between 2011 and 2012, we had a pretty significant drop in almost everyone, up to 52% in one physician. The only doctor that didn't drop on his radiation badge was an EP doctor that was already using the lowest setting. So with the difference on this between these 2 sets of numbers is just going down to 7.5 pulses on our fluoro instead of the 15. We also made some other changes, but the one thing we did right off the bat was we changed every room, so the default setting was 7.5 on the fluoro. So when we turn the machines on in the morning, everyone is 7.5 unless they ask for a change. And that was a pretty dramatic change. And then what happened afterwards that cut us tremendously more is within about a year or 6 months, we purchased zero gravity.
Something on the previous slide.
Yes.
Are those, so this is just the 7.5 you said, right? And these are, what kind of machines do you have?
We have all GE, all General Electric.
Okay. So you made them default at 7.5 and low fluoro setting?
Low fluoro, that's exactly right. So we have the fluoro set at low, and then we're trying to, the things that we know should be done, but it's hard to get everybody to do them consistently, is to do more collimating and less magnifying and things like that. But the things we were able to change without anyone having to think about it every day was having the default settings, so low fluoro and then the low pulse rate on the fluoro. It's 7.5.
Perfect. And then I see some physicians have like a very high, like 1,200, etc. These are EP, I presume EP physicians, more ablations.
Yeah. So that's exactly right. So I think the 2 that you see kind of stand out here. This is electrophysiology, and I think, and this is a very busy electrophysiologist that is in the lab pretty much all day, 3 days a week, and then some other cases in addition. And then this physician that's high here does a tremendous number of complex lower extremity cases, including he does the wound clinic and a lot of limb salvage. So really he is not uncommonly right up. Those a lot of times are hard to do without getting pretty close to the II, and so I think some of that is related to his proximity and the length of the cases. But he does a lot of tough, long cases. But they had the two largest numbers, and then mine is actually right here, which was not that high to start with, and part of that's just because I typically stand back. Once I get ready to step on the pedal, I kind of take one step back from the patient, and I do a lot of other things. So you can keep it low even with a fair volume, without doing these things. But
Perfect.
The zero gravity, go ahead.
The point, doing CTOs helps you, I guess, just the simple things you do helps you for everything else, and that's a classic example of what you just showed us. It's beautiful.
Yeah, I do think anytime you can fluoro and fluoro store, all these things we're learning by doing more complex PCI and having people visit our lab or us going and visiting their lab and sharing little tricks, it's been a quantum leap forward for us because I've been an interventionalist, just at this place 21 years. we've made very few changes until the last 2 or 3 years, and now we've, I wish we would have made these changes when I was young, but certainly we've learned a lot and made tremendous changes in our safety, and we made another big jump when we changed to zero gravity, and you can see this is a suspended lead from the ceiling, and it pivots, so it's actually hanging from a single cable that takes all the weight off of you. And this is a very large gentleman. He's very tall. He's 6'6", but usually my eyes are a little bit lower into the plexiglass, so we've watched what our doses get even to our brain and eyes, and this has had a dramatic drop-off. So even all doctors combined with the badges behind the shield are just 30, 40, 50 millirem per quarter for all doctors combined in a room. So it's reduced our radiation another, almost 90%. Plus having no lead on your body, this is extra thick lead compared to what you wear, just because they can have all the extra weight since you're not carrying it all day. So this has, I think, been a tremendous advantage for us lately.
Okay, and Tony, tell me again, what was the cost for the people? I guess the main concern is about the cost and the ergonomics of this.
The cost is probably, for me, the only negative. It is, some people say in the beginning it's a little awkward, and I would say that's true your first day or 2 or 3, but afterwards you forget you have it on. The cost is about $65,000 for a floor-mounted unit and about $85,000 for a ceiling-mounted. And if you can talk your administration into it, the ceiling is tremendously better because you don't have a big, thing on your floor that you trip over, and the ceiling, you can really walk all the way around the patient table with the ceiling mount. So if you can talk them into the extra upfront money, it really is tremendously better to have the ceiling mount. But it is very expensive. That's the key negative. I'm hoping as more companies get into this, I'm sure there will be more companies and the cost will come down. It's been rolled out a little slower than I thought, just because I know they've been backed up on getting them in labs and things.
This is perfect. I think there's something that we've been considering here, and cost has been the issue, but also there's a concern that if you move quickly, you might not get used to this or bump your head or not feel. But from what you're telling us, it's not really a big issue, right?
I was surprised how fast we had 1 or 2 guys say, "Boy, it's really awkward that first day." Now there's not one guy that doesn't use it for every single case, even STEMIs. We do radials, we do carotids and peripherals. People that that visit love to try it. So the one thing, if you're used to looking at your foot pedal, you can't look at that quite as easily because it's right straight down from this thing, and so the people from the company did tell me that people that have a little trouble getting used to it are the people that like to look at their foot before they step on the pedal. But if you're used to not ever looking at your foot, which I think most people that have done it a while are used to not looking at their feet, you can get used to it very quickly.
This is perfect. Excellent. That's a great introduction. Again, great example of how CTO can help you in other areas as well, apart from the CTO per se.
Exactly. We might go on to the first case. The first patient is an 81-year-old gentleman. This is a case that was earlier in our experience, and I might do it a little differently today, but I think we still learned a lot on this case. 81-year-old gentleman that had an old bypass in 1992, had been having fairly prominent limiting angina and dyspnea on multiple meds, and probably the key reason this gentleman had a vein graft to his right coronary artery, which I'll show you in a little bit, which had been stented on a couple of occasions, and subsequently that vein graft occluded to a big dominant right coronary artery, and so that'll be the case today. He had a large area of ischemia, 22% of his LV mass by nuclear imaging. And this is actually from his diagnostic film. This was performed by one of our non-interventionalists. You can see the proximal right coronary artery. These are just 2 branches. It's really a very ostial occlusion, a couple little branches coming off right at the ostium, but really nothing to hardly even set your guide into. If you look carefully, you can see an old stent in this vein graft up on the left, and there's an old stent down here in the vein graft right where it inserts to the native right, into the native right coronary artery. Here's just a picture of that graft. This probably occluded in the last, probably about the time you started having more angina 6 months ago. This was stented about a year before this procedure. And so then you'll see on the next picture we have guides in both vessels. We've got an Amplatz 0.75 in the right coronary system. We have a little trouble getting it to seat, so we actually seated in one of those branches that you saw earlier. And then you'll see there the left coronary guide as well. This person had already had a CTO opened up on his circumflex.
Okay, and Tony, this is side branch, side hole guide that we're using?
Yeah, we tend to use side holes quite a bit. You know, these are large guides. Frequently they fill the ostium. We try not to do very much, as you know, injecting, but these do have side holes. And it does fill that little branch, but I think we learned something great on even being able to intubate that branch. Here's just a picture of your left system. Usually we'll inject these simultaneously, but because the right just didn't hardly fill anything at the ostium, we just shot the left to conserve a little dye. And you can see there's a mammary patent, and the LED is not really that severely narrowed, but there's some great potential collaterals from the septal system. And so our original plan, since we didn't have much to work with at the ostium, was to just see what kind of progress we could make retrograde. And just in typical fashion, we brought a Corsair down with a workhorse wire into the septal, and then we switched out. In this case, we ended up using a Scion wire for this part of the case. So you can see the wire comes down into the PDA, but here's the problem we had initially is either the stent or something recurrently deflected us toward the graft instead of up the native right coronary artery. So if you're not used to doing these, it's not uncommon to find your wire way out of plane, and you can see this wire goes all the way up to the old stent in the vein graft where it's occluded, but it's not really where we want it, which is over here by the right coronary guide. So we carefully What's that?
Tony, one question on the retrograde. So did you do surfing, or you went with looks like more contrast guided? How did you cross this septal?
So we gave a little bit of contrast to pick the septal, and then we mostly surfed. We typically on the septals will start with an FC and see if it'll go through, or very quickly sometimes go to a Scion or occasionally even a Scion blue. But on this, usually we'll try to surf with very little. Once we pick the collaterals that we think will give us the best chance, we'll just surf with one of those two wires. And then and once we get to the base of the heart down here, we're kind of looking for this, this curve that you're used to, where it kind of curves a little to the right before it then goes to the left. And in this case, we were pretty confident we were in the PDA early, but we had trouble, tracking back up the native vessel. But here on this shot, you can see we did switch out for a Pilot 200 wire, and we brought the wire up into the distal cap. Eventually, we did knuckle it and work it a little bit further. But I think what was interesting here is that, so what I might do different today is I might have tried to make a little antegrade progress first. But on this particular case, we thought we would try seeing if we dilated the ostium right inside that branch, but mostly out in the aorta, if we could crush the ostium just a little and possibly do an open sesame where we change the plaque at the ostium and maybe let us get through. And I would say this is one of my better examples of an open sesame, because we just took a 2.5 millimeter balloon and just had it slightly in that little branch. And then we left the balloon setting in that branch. We deflated it and pulled it back about halfway, but we left it setting in the branch so that it would keep our guide from falling out. Our guide recurrently wanted to fall out of this vessel. We thought it might just steady the guide. And then beside the balloon, we brought a Fielder XT wire, which interestingly came very easily, without even knuckling or anything, came right down into that space to here. So that might even have worked a little better than average, but our hope was it would at least let us get a little fissure so we could get started in the architecture of the vessel and make some progress.
And I thought in your case, actually, the initial retrograde was perfectly right, because you had an ambiguous carp. You didn't know exactly where the vessel was starting. It was a very long occlusion anyway. So I think the primary, and you had good collaterals, right? So
right.
Good to start retrograde to start with.
Still reasonable to go that way. So here's after. So I take a couple pictures out in the interest of time, but we did knuckle so the wires were crossing each other, and then we pulled them back a little, and you can see we brought our corsair up retrograde into the distal calf and even into the occlusion a little ways, and the wires are dancing nicely together. And then we did bring a balloon over the antegrade wire and balloon the space right here where our corsair is coming up to. And once we let the balloon down, the wire actually drove nicely into the guide. If we would have had trouble, we might have brought a guide liner down. But in this case, the wire here, with just a little manipulation, was able to drive into the guide. So then we did bring our corsair all the way into the guide retrograde, and that allowed us to externalize. At the time, we were using a less friendly externalization wire. I think back then we were even using a Viper, and we switched eventually then to the R350, and now we're using the RG3 just as of the last couple of weeks, which is a dramatic improvement, as I'm sure you're aware. But back then we used a lot of Rotoglide or Viper Glide to help facilitate externalization.
Well, this is good for the listeners also to just, because many people don't have the RG3 yet, so it's a good thing to just reiterate what wires are available for externalization. So as you said, the Viper was the initial choice. We didn't have anything else. Then now we have the R350 from Vascular Solutions, which is 350 centimeters long. So if you don't have short guides, that's a very useful wire. But the best wire is the RG3, which I think, again, many people don't have it yet. But this is a little thinner wire. I think it's 0.010, if I remember correctly. Yes. And we used to use Rotoglide. I don't use it anymore. I don't know about you, Tony, but this wire is so good, we can advance it very easily and externalize, even without adding Rotoglide into the microcatheter.
No, I agree. It dramatically simplifies the case, and I think it may even make it safer, because when you get ready to remove that long wire, you're not putting as much tension then on your coronary tree and your guides and your ostium of your vessels. And initially I said, well, we'll just try the new RG3 and then we'll use up our old wires. But now I'm not sure I want to use up our old wires. I really like the RG3. It's a leap forward that's pretty substantial. So I agree with you. And then hopefully everybody can get it.
Yeah, and I think it's actually now, I think, in general release, so as long as people are asking for it, I think you can get it at this point. And again, as you say, this really makes things much easier. And then another question here is, so this one was true-to-true crossing. You just went the wire, no reverse card, nothing, the wire just was able to cross, or kissing wire?
So actually, I took out that picture. I left that out, I'm sorry. But yeah, when we had the wires overlapped, we did bring a balloon down antegrade, and it was a large 3.5 balloon. And we just ballooned right over this corsair, right over the tip of it, and then we let the balloon down and pulled it back into the guide here beside our trapper, and or beside maybe our other balloon that was used for the little branch. And that did allow just the balloon dilatation for reverse cart did allow us then to without much trouble drive the wire back out. So we didn't have to use a series of balloons. This one worked pretty nicely.
Perfect. Excellent. And that's a great picture of the wire coming back in.
Yeah, and then so we basically then went ahead and put in two large 3.5 millimeter stents that go down to this old stent. So there's an old stent here on the horizontal segment. The two new stents go back up to the proximal right. You can see after we stent and remove the wire, luckily we keep the RV branch, even though it's compromised some, it still has good flow. And you can see where the vessel's tented back here from the old vein graft, which we were going up with our wire. But anyway, I think it's just a good case as far as showing all the different options and tricks that can help us.
I think this is perfect, Tony, and this is an excellent result that you achieved. A couple of questions here. So one is, we see the stamp of the old vein graft, and I think there was actually a case last year in the CTO summit where they were doing a similar retro case, and they have the issue like you did in the beginning, where the wire kept on coming into the occluded bypass graft. So to take care of that, what they end up doing is either what you did is do a knuckle, but it didn't work in that case, so they actually did a little reverse Carlino. So they put the corsair all the way to the beginning of the graft, and then injected some contrast, like half SCC retrograde, and that kind of outlined the pathway towards the true lumen, and then they were able to take care of that. So that's one.
Okay, great.
That's a problem.
Yeah, sometimes it can really be a problem because you can see, I've had times where I couldn't hardly get it to quit going in the graft, so I think that's a great idea, but you can almost see where naturally it's going to want to follow that graft when you're coming retrograde. But usually with a little bit of changing the torque or the angle on your wire, or even changing your wires, usually it'll find that lumen. Fortunately, it did on this one.
Yeah, exactly. And I also think that in this particular case here, the graft, I guess the angle was favorable. If you have some more tenting, sometimes the grafts tend the distal vessel more, then it's when it becomes even harder.
Right. And that can even throw off. Yeah, go ahead.
Exactly. The other interesting thing here is that in spite of doing dissection reentry, your reverse cart, you still have, as you said, the acute marginals there. And we've seen some similar cases. So I don't know how exactly this works, but probably you've seen that as well, where you do a reverse cart or you do an antegrade dissection reentry and you stand, and then you still have the side branches.
Right. That you always hope you'll have them. I did see it where one of the physicians, I think Cal, presented a case not too long ago where losing the right ventricular marginal did really compromise. A lot of times we kind of ignore the branches or don't worry about them too much, but occasionally one of these little branches, or if it's a bigger RV marginal branch, occasionally the patient won't tolerate it. Or sometimes you'll see some right precordial elevation on the EKG afterwards where you get a little RV injury from losing a branch. So it's nice if you can keep those branches.
Yeah, absolutely. And then Dimitri actually, Karbaliotis mentioned to me recently he had a case where he did a dissection reentry on the right and sheared off acute marginals, and the patient went into acute shock from RV infarct. So his RV swelled up on the spot, and actually he put him on ECMO and was able to wean him off a couple of days later, but otherwise he was going down very quickly. So it's very uncommon, but it's something to keep in mind. It can happen. I think people are realizing more and more acute marginals are usually okay, but sometimes they can cause real trouble.
Right, exactly. It makes you respect everything just a little more, just knowing it's a possibility.
Yeah, actually, I had one of the course case, and we did a similar ride, and the patient arrested in the recovery room. So I had much more respect since then. I mean, he was fine, but I had much more respect since then about the acute marginals.
Exactly. They usually do recover just a little bit at a time if you just kind of can support them like you did and Cal did. Perfect. Okay, well, we might go on to the second case. I think this is kind of a fun case, or at least an interesting case of a 65-year-old very active lady that likes to exercise and had been having more angina. You'll see she really has two-vessel disease. She's followed by a non-interventional but an invasive cardiologist. He did a stress test on her. She had a moderate-sized area of only anterior ischemia, severe ischemia anteriorly. She was on 2 meds. And she was brought in, and he did a diagnostic cath, and then asked the guy on call to look at it. And you'll see on this case, I'm not even sure this is a CTO just looking at it. These are the diagnostic. These are a couple representative pictures of the diagnostic film, but you'll see the LED has a little gap in it right where the diagonal comes off, and you're not 100% sure. There's not a little bird beak or anything where you're sure you want to put your wire. But you have a pretty good idea since it's such a short area of occlusion. And they did decide to go ahead and just try to open it at the time of her diagnostic heart cath. And they tried several different wires, including a Fielder XT, but they tried 3 or 4 wires, some of them which we don't use that much anymore, but including a Pro Water and a Whisper and a Crossit wire and an XT wire. But you can see the wire. This is the last picture of that case. The wire's definitely subintimal, and you still have flow down the vessel, and the patient was doing great, and so they decided to stop there, and she did well and let her go home. And we looked at the films and discussed kind of, is this a case that we could potentially do in another fashion? So this has happened to us a couple times. This one may or may not have been a true CTO. But we've had cases where either a wire's accidentally gotten pulled back or where some complications occurred and the physicians ended up subintimal like this, and you're kind of stranded. And so I think these are nice cases where you can sometimes use a stingray to bail you out. So I'm just going to show you the next pictures when we bring her back 9 days later. So this is 9 days later. We do a dual injection, and you'll see she has some disease in her right coronary artery, which we're which we're aware of, but we don't address at this time. We were going to see how she did initially by just trying to establish good flow down her LED. You can see a little bit there where the dissection was created from the initial attempt. It almost looks like there's a microchannel, and I was hopeful that we might just be able to wire this lesion, but we did bring down a Corsair, and we tried an XT wire, and just couldn't get it to go where we wanted. But it does eventually kind of go back in the same plane you saw in the previous picture, and it looked like it was on the upper surface of the vessel. And this kind of sets us up for several options. We've got good collaterals from the right coronary, so we do have that option. But it's a straight shot. She has a good distal target, and our real plan on this case was to consider reentry with a stingray. And a lot of times we'll switch this out for a crossboss, but this lady did not have any calcium, and it was a short area, and so we decided to just bring our Corsair down, make a little path, and then use a wire to exchange out for the stingray. We used the Miracle 12 wire.
So Tony, quick question: do you think Gaia's might have helped in cases like this one in the future?
Yes, I think so. We're just starting to get some experience with the Gaia. We've played with it here a little bit lately, but yeah, this is since it's such a steerable, penetrating wire, I think it might have helped a lot. I'll be interested. Have you had much experience with the Gaia yet?
Yeah, not much. We had it since December, so like 3-4 months now. And I must say, we've been very impressed with it. We were able to cross very long CTOs that I never thought that would be able to cross through lumen, but it has happened. I mean, it doesn't work obviously all the time, but it does give you some additional equipment. And I think now I understand a little better, the Japanese way, where they really insist on doing wire escalation and parallel wiring than doing the reentry. Because sometimes, this is much better equipment, and your chances of getting through is much better, I think.
Well, we're looking forward to that. So I want to get more experience with it, but it does seem like a very steerable, excellent wire, and you do hear the Japanese speak very high. Everyone that's tried it speaks very highly of it. So we'll hopefully get some more experience. But on this one, we brought the Corsair down to the tip of where you see this wire in the as far as it goes, and then took out our wire that we had, which was an XT, and we put in a Miracle 12. And this is the Miracle 12 with the stingray. So you can see on this picture, as we bring the 12 back, you can see the two balloons, the two parallel balloons of the stingray. And so we know we're in a plane that's not ideal for reentry. So we move the camera around a little bit. You'll see in the next view, it shows the single balloon in profile. So we know, and we also knew from some of our injections that we were pretty confident we were on the surface or in the upper part of the vessel and not the lower part. So we really wanted our wire to exit inferior instead of superior.
It looks like you're very compressed there, right? Your vessel is very compressed, LAD.
Exactly. I think we're getting a subintimal hematoma probably a little bit here. We did not have a lot of trouble with that so on this shot here, just as Manos said, the dye is not going back up as far and nicely as we thought. So what we did is when we took out this Miracle 12 and we were getting our next wire, our stingray wire, loaded, we did straw for a little bit. We put a 10 cc syringe on the end of our stingray and just pulled for 30 or 60 seconds. Sometimes we'll do it longer, but on this particular case, we just did it briefly, and then we brought down our stingray wire. We actually made a pass with the stingray wire and decided to swap out. So this is the swap, and you can see it's coming. It's hard to tell, obviously, because this thing's always a little hard to see, but the wire is coming out below the dot on the end of the balloon. But the wire moves fairly well, and does not knuckle or act like it's subintimal. So you'll see when the wire first comes out, it's looping here, it's going to play again. When the wire first comes out, it's probably going down a septal and then maybe a diagonal. And on this retrograde injection, you can see the LAD is down here. So we pull it back out of that diagonal, and it drives down the LAD. And then after that, it's pretty much a standard case. We always try to get that wire out. This is a Pilot 200 that we swap with. So we swap. We use usually we'll use an over-the-wire balloon that will swap out the Pilot 200 then for a workhorse wire, maybe something like a Pro Water, and then dilate and stent. So that's what we did after we had the wire distally in good position and we were sure that we were true lumen. We just dilated with a small balloon along this segment and stented.
So Tony, this was more like a blind, right? A blind sting in a way, because you couldn't see the vessel. But as you see very nicely, you were able with the Pilot to go down and find the true lumen.
Right, and it seems like that it's always nice when you have a great visualization of the vessel beside your stingray, but it's not uncommon. It's not great, and it seems like more and more meetings people are showing cases. I know at the CTO Summit, Bill had a nice one. Bill Lombardi had a nice case where he went in kind of a double blind. He stuck both ports of the stingray and then brought out his wire for a stick and swap, and worked nicely. And sometimes the wire, these Pilot 200s are great at finding that. Sometimes you'll know your subintimal when you come out by the way the wire just doesn't move right and it seems to curl a little more, and other times it really acts like it's in a branch or the main vessel. So I think if you're just careful not to make your subintimal space bigger, you can do that successfully a fair amount of the time.
That's perfect. Actually, we had a case, I don't know if it happened to you, had a case actually yesterday where we did reentry, but the wire didn't re-enter actually where the balloon was. I think the wire went down maybe another 20, 30 millimeters and re-entered further down in the vessel. And we found out something IVUS, and actually we thought it was a minimal much longer than we thought. Wow. I don't know if it's happened to you in the past, but it's one of those things that, what do you do?
Yeah, no, I agree. Well, I do think the stingray is a nice thing to have in your, even though a lot of cases like this one have several options, you might have been able to do this, like you said, with a Gaia, or you might have been able to do it retrograde, or some people may have even just been able to wire it antegrade with another wire. But we've had a handful of cases, including a case on a malpractice attorney that the wire got deeply subintimal, and there was a lot of concern they were going to have to go to surgery during a regular intervention, that we were able to switch out quickly for or help somebody that was in the middle of a case switch out for a stingray and get back into the true lumen. So sometimes it can save you on even a non-CTO case.
Absolutely, and that's actually even easier to re-enter in those cases, because the distal vessel usually is not diffusely diseased, but it's kind of more normal than the CTO. So it's nice to get to re-enter. It's much easier than a CTO. Exactly.
Well, great. Well, we may go on to the third case.
Perfect. Yeah, that'll be great.
So this is a 64-year-old that's had long-standing angina. This is again kind of a fun case. This gentleman, I would say he's about 2/3 dyspnea and about 1/3 chest tightness. The thing that bothers him the most is exertional dyspnea. He's never been a smoker. He's a hunter from South Missouri, very active. He's been known to have a CTO for a long time. There's a hybrid CTO operator about 100 miles south of us that we have worked with some getting him going as far as proctoring, and he's gotten a good experience going. And he had tried doing this case. It's a proximal circumflex, which seems like the circumflexes, as you know from some of the databases, are not the most common vessels we do with CTOs, but they come up every once in a while. And he had tried to open this circumflex about 2 months earlier, antegrade. And the patient did have moderate ischemia and was on beta blockers and nitrates. So I'll just show you the case. Now, the reason we're going to only use one guide on this case, and the reason we took a picture of the right first, is 2 months had passed since he had tried him in South Missouri, and we thought we just wanted to make sure there was no hint of collaterals to the circumflex from the right coronary that had developed, because it would be nice to do this case if there was a nice collateral connecting to the circumflex, do a nice retrograde case. But unfortunately, this one does not have, we didn't even see a hint of any right to left collaterals. You'll see the reason. And there's pretty extensive collaterals from the LAD. So this is just a single 8 French guide injection, just a little bit of proximal circumflex present. And then you'll see a little branch here. That is not a continuation of the circumflex, this little branch. So the circumflex kind of comes off you'll see by the retrogrades, kind of comes off a little bit above that branch. And when I saw the pictures, I thought, well, this will really be a better case to do antegrade. We could do it retrograde through this collateral. I'll show you the next picture so you can see the collateral from the LAD, but it's a pretty unfriendly looking epicardial collateral with tremendous tortuosity and loops, and so we were a little concerned about trying that. So we thought first we would make a pretty serious attempt to antegrade, and our original plan was to bring down a Corsair catheter and try with a Pilot 200 wire, and we even tried with a Pro 12. But the thing that was interesting about the proximal cap on that Circumflex is it was fairly mature, and our backup was such that every time we hardly did anything, we tended to prolapse into the LAD, and we just weren't making any progress into that cap. And there's not enough room there to really, to put up a balloon in the proximal Circumflex to use a power knuckle or another technique. I don't know if you have any other great ideas on an osteal Circumflex like that, short of going retrograde, Manos. But we had trouble getting antegrade.
Yeah, it's a very challenging one, and actually in the Progress CTO, in the registry, the Circumflex CTOs were the lowest success rates in the mid-80s versus 90+ for the RCA and the LAD. The one thing that I think might be of use here is having a venture, so the venture over the wire venture to give you a bend and an extra support. I don't know if you use it much, but this is a nice solution for osteal circs. The downside is it's very bulky, and when you turn it, it's fairly stiff. So you got to be very careful with it because you can dissect the vessel distally. But that's one thing potentially to try in osteal circs.
Try a venture. We did not try that. We did for a little while we tried bringing a guide liner, a small guide liner, a 5.5. I thought if I could get the guide liner to just point down into that Circumflex, I might be able to get enough backup with the Corsair and the guide liner to make some subintimal progress. But we just didn't make any progress because the angle is probably just a little more unfriendly than it appeared. And so we did decide to just see what would happen if we carefully wired this epicardial collateral. I think we always really respect these.
About how you assess them? Many people don't have as much experience in retrograde. Can you just tell how? So you should look this collateral. What are the things you look for to say, this is something I would try, I would definitely try, or I would definitely not try, or maybe I can try and see how it goes?
Yeah, I think this is probably the thing I like to try the last option. Like I'd really like to see some collaterals from the right, or I'd like to see something tempting from the left, or I'd at least try to go antegrade. So usually I'll use for epicardial collateral, especially this tortuous, we'll try to avoid these if we can, and we only try them. You would only want to try it if you also, as you know, if you had a pretty good plan, if you cause some trouble, because every once in a while somebody will show a case where a collateral gets torn or avulsed, and that can be a life-threatening event. So I showed this to Nick Limbo a while back, and he even mentioned he's got a tremendous experience how he's always nervous doing an epicardial collateral. So he said that never really goes away. So I think we just would kind of say that's your last resort and do it very, very carefully and not do a lot of pushing. I'd say for me at least it's a little more with the Corsair and everything else, just gentle forward pressure and some gentle spinning with time, giving it a little more time to move forward, not be in any kind of hurry to push something through that kind of nest. And this is probably something you don't want to do your first few cases. This is, maybe after you've done some septal retrograde cases, at least as far as what I would recommend. I already have a pretty good experience behind you.
And then, Tony, do you leave your Corsair further away from the tortuosity and just go with the wire, or you try to bring it closer? How do you typically like to approach this?
Well, on this, so we actually on this one brought it through those collaterals, and it is possible, if you got a real short CTO, that you might be able to not bring it as far forward. But the problem is, at some point, you got to figure out.
No. I'm saying during wiring, not during when you try to wire the collateral. Do you try to leave the course back to avoid the extra?
Yeah, we brought the wire pretty much through, almost all the way through those coils before we advanced the Corsair much. We brought the Corsair kind of up to here, and you'll see on the next shot, I might have even left it out, but we brought the wire up into here, and I'll tell you, when we got to here, the wire stopped pretty firm. It did not want to go any further, and I didn't push it very hard, but bringing the Corsair into these, I was amazed how it made the turns, and then it suddenly made the wire very easy to manipulate, so that we were able to go retrograde pretty nicely. But the one thing that did spook me, and I think I learned on this case, is, and I've seen this several times, I'm sure you have too, where these incredibly tortuous collaterals can sometimes really move or change, and it scares you that they tore or something, but a lot of times they'll go back to their regular shape as you take your gear out. But it is good to have a plan, either coils, or you really want to, when you remove your gear, you really want to have a great plan on how to deal with a perforation or a tear in a collateral if you get one. Hopefully you won't ever get one, but I would always kind of plan that you might get one so you have the gear ready if you're going to do one of these cases. Either epicardial fat or either sub-Q fat you can use, or thrombin, or a coil. There's several things you might want to have available. We haven't had to use that.
Do you prefer the fine cross or the Corsair for this, or the turnpike? What is your favorite microcatheter for these epicardial tortuous collaterals?
My favorite has been the Corsair. I love the fine cross, and you've got a lot more experience than me, but for me the fine cross has worked great when I get stuck in a septal and I can't get the Corsair. I got the wire across, but I can't get the Corsair to go across the base, way down the septal, maybe from an LAD to a right. And I seem in Circumflex epicardials and some of these other epicardials, I seem to do best with the Corsair. What are you seeing? Are you having more luck with the fine cross on these, or?
No, I agree. I think you're right. The Corsair has a little softer tip maybe, and a little more softer taper tip, so it takes bends very well. I think I've used both, to be honest. Sometimes the Corsair gets stuck; it doesn't move, and the fine cross, because of the lower profile distally, might move. But the other way around too. I've seen cases where the fine cross doesn't move and then the Corsair goes. So I go either or. The turnpike I haven't used much enough to have much experience. To me, it looks a little stiffer. So I would say it's mainly for septals. I'm not sure about its applicability for the epicardials at this point, at least.
Okay. Yeah, I don't have any experience with the turnpike yet. I'll just show you. Go ahead.
I'm sorry. There's a new one coming out called, I think, the Mini Cross. So there's more microcatheters coming out from Roxwood. So we'll see. We'll see more things as time comes by. Companies get better and better in getting more, better catheters to track.
Right. Yeah, I think one thing that's been shocking to me is the progress in the field in the short period of time I've been involved. So even in the last 12 months, the new wire, there's been a lot of things learned, a lot of new tricks that I've learned from you and Aaron Grantham and Lombardi and Wyman. All these guys keep coming up with things. I'm amazed by the progress made in the field. I think this is a kind of interesting, intriguing picture to me, just because it shows the abilities of this microcatheter. This is the Corsair, to really not dramatically change this collateral, at least initially. And so it actually was able to spin fairly easily to here, and it allowed us to get our wire in a little more secure position. And then the part that I think concerned me, or where my heart rate went up a little bit in this case, is when we brought this Corsair up a little further, you'll see the collaterals changed very dramatically. And and about a week before this, one of the guys had shown me a case where the collateral got avulsed, and that was very fresh in my mind, and so I kind of was pretty nervous. But we spritzed, and there was nothing concerning anywhere, so we decided we're going to go ahead and try to finish the case, and if we have to coil something at the end, we didn't see anything leaking, at least, when we did a general antegrade spritz. So at this point, this wire up until now had been the Scion wire. At this point, we switch out for a a Pilot 200 wire. And this case has a pretty nice microchannel retrograde all the way back up to it's a very short CTO. So our hope was, and you can see with the injections that were just a few millimeters from the other side of the proximal cap. So what we did is we just tickled the wire up, and as it got up to that proximal cap, it actually just within a few seconds went through the proximal cap. So much easier to go through retrograde than it was antegrade, which seems not unusual. I think we've even written some about how long that a lot of these cases have a retrograde microchannel that's been shown on some autopsy studies and can be longer than you maybe appreciate. So if you kind of play with your Pilot 200 or your Pro 12, a lot of times you can get very close to the proximal cap without much trouble. And in this case, we just drove the wire right into the guide. We're almost there once it comes through the circumflex. And because I was a little bit nervous with the case, we did go ahead and bring our Corsair all the way out guide and externalized and stented. But we ended up getting antegrade access as well, which you'll see here in a little bit. So here now we're bringing a wire or a balloon. So we've already externalized at this point. We're bringing a balloon down. Yes. A
quick question. So you externalize versus the same guide, I see? You use the same guide for externalization versus a different guide. Any thoughts on that?
Yes. We just externalized with the same guide I think like you're mentioning, there's some people will put two guides there. I'll frequently do it with just an 1/8 guide, but I think both approaches work great. Usually the 1/8 seems to have enough room carefully to do this. But even I'm still amazed when you look at the epicardial how much it straightens. So we're kind of watching that as we're doing all of this. But we did then go ahead and dilate and stent, and then what we did is before we pulled our wire and everything back very far, after we stented, we brought down a microcatheter and an antegrade wire as we pulled our other wire back, just in case we needed to coil or put thrombin or do something on both ends of this epicardial, because I still was worried by the dramatic shift in the microcatheter. You'll see at the end that we were fortunate in that this epicardial collateral basically it's still there, but the dye meets in the middle between the LE and circ after stenting, and we don't see any extravasation or any trouble, and all the curls come back in the epicardial. But it's not uncommon that I think I at least feel a little better, and I've seen many people do this in meetings, and I've seen the Japanese talk about this too, where they sometimes will get antegrade wire access just in case they have to put a coil or some thrombin or fat, something, both antegrade and retrograde in this collateral to shut it off from both directions.
Yeah, absolutely.
Anyway, that's the final
thing to do, just in case.
Just in case. For septals, it's probably hardly ever necessary, but for the epicardials, makes you a little more nervous.
Absolutely, and I think also what some people do is they will leave the wire in and pull back the microcatheter a little bit, take an angiogram, and see if there's an extravasation before pulling the wire back, so they still have access to the area of perforation. Or if they don't do that, at least what you're showing here, keep the wire into the collateral, so if you need to do something, you're right there, can deliver and give the coil or thrombin or whatever it is.
Exactly. No, I think that's another thing. If we're not too worried, that's a great way to approach it, to just make sure, because sometimes even when you're not worried, you have a little trouble that you're not aware of. A lot of those will probably seal, but just to be on the safe side, that's very reasonable.
That's a beautiful case. Yeah, I think many good lessons on that case, and then in the end, the other thing I was just wondering is, so you have here the entry very close to the left main, and I guess the nice thing here, it looks like you went 2-2 through, right? You didn't have to do any re-entry maneuvers, any reverse cart or anything like that. If it were, I think what we do often is we'll try to get a guideliner down there, because we've had cases where we re-enter, and then we end up re-entering through the left main, and then you stand, and then you get the circ or the LAD in this case in trouble. So I would like to try to re-enter a little further down if at all possible.
Wow, that's a great idea. That's a great teaching point. Yeah, many people have shown cases where when they try to do an osteo-LED or an osteal-circ, where occasionally they'll get a little surprise there at the end in the left main. So I agree, these are ones to respect a lot, and I've been impressed with how far you can get retrograde if you just spend a few extra seconds sometimes. And I think some of the autopsy data that people have shown on the retrograde microchannels has helped me, at least in my mind's eye, kind of envision, what I'm trying to do retrograde, so that if you can get all the way to that cap, and this is a case where the wire just went true to true, and that certainly makes it simpler and lets you save the branches a little easier and makes it more of a standard intervention, a little bit lower risk. So yeah, he did find these each case seems like we learned a little bit more from. Okay, are you still there, Manos? Well, I think those are the key things. So we may have had a connection problem. Hopefully you can still hear me, and we'll probably pause here just a little bit and see if we've got Manos back on.
Once again, I would like to thank Dr. Spaedy for 3 amazing cases. It is impressive what the new techniques, retrograde and antegrade dissection reentry, can open for us in tackling some very, very challenging cases in a successful as well as safe way. Hopefully, lots of tips and tricks discussed today can help you also advance your CTO or other complex percutaneous coronary interventions. We'd like to thank our sponsors, the Rumo and Upper Vascular, as well as the Dallas VA Research Corporation, and hope to see you in our next webcast, which is going to be held sometime in July of 2015. Thank you very much.